Thank you for joining us for AAKP's 45th annual patient meeting. I'm Ed Hickey. I'm an attorney and veteran U.S. Marine Corps infantry officer. I'm honored to serve AAKP as the newly elected Vice President and as a member of AAKP's Board of Directors. For the past several years, I've served as chair of AAKP's Veterans Health Initiative, a role that has been of particular importance and a responsibility that I will continue to retain. I've held positions in government over the past few decades and am now in private practice. While in government, I was responsible for implementation of several initiatives related to veterans and was designated liaison to the veteran service organizations in Washington, D.C., to the Director of the United States Civil Service. In that capacity, I received several awards for representing interests of our great veterans, including the prestigious Silver Helmet Award from AMVETS. I've managed kidney disease for 5 years as a chronic kidney disease patient and also as a caregiver. Veterans and their families face many unique challenges related to managing their health care, and this is especially true for veterans who suffer from kidney disease and other complex chronic diseases. I'm committed to making certain my fellow veterans have their voice heard, retain access to the care they have earned, and are legally entitled to at the VA and elsewhere. I believe it is essential that veterans and their families gain the benefit of new research and innovations in the realms of biologics, diagnostics, and devices. The VHI, based within the AAKP Center for Patient Engagement and Advocacy, is designed to advance research, innovation, and policies aimed at safeguarding the highest standards of kidney care and treatment for veterans managing kidney disease, both inside and outside the VA system. AAKP rolled out the VHI in 2017, appropriately at the groundbreaking Kidney Innovation Summit at the U.S. Department of Veterans Affairs in Washington, D.C. Since then, we've undertaken several educational advocacy initiatives, including a most recent COVID-19 webinar for veterans and their families at the outset of the pandemic with our friend and ally, Dr. Susan Crowley, Chief of Nephrology Services for the VA. AAKP proudly serves as a source of patient experience with the Department of Defense, and our role as reviewers for the DoD Congressionally Directed Medical Research Program, or CDMRP for those in the Pentagon. Evaluating research proposals that may accelerate kidney research in areas of benefit to current uniformed service members and the broader kidney community, including veterans. Beyond government, AAKP has actively supported private sector firms involved in medical innovations that have implications for both American military personnel and veterans, as well as the broader kidney community. Several of us who serve on the AAKP National Board have a direct professional understanding of how DoD policies can jumpstart medical innovation and new technologies that lead to commercial availability. These newly commercially available technologies have life-saving treatments and also introduce new devices. Our close collaboration with Humacyte, for example, was inspired both by their novel product and support from the United States Department of Defense. We also partnered with the American Society of Nephrology and the United States Department of Veterans Affairs to recruit patients to test a new nutrition mobile app for veterans and other individuals managing kidney disease. And we're participated in virtual events with Career Echo to connect employers interested in hiring with patients, including veterans who work hard to balance disease, disability, and their desire to work. We honor our nation's veterans throughout the year on social media. AAKP patient members, ambassadors, and board members share with us photos of themselves and their loved ones so that we remember those who serve the nation in uniform and who continue to serve the kidney community throughout their own efforts or those of their families. Today's panel is titled America's Veterans Kidney Health During COVID-19. I'm pleased to introduce the following special panelists who will discuss this topic. Dr. Rudy Rodriguez, Chair of the ABIM Nephrology Specialty Board, and Vice Chair, Department of Medicine, U.S. Department of Veterans Affairs, Puget Sound Healthcare System in the state of Washington. And Ms. Jennifer Jones, a fellow USMC veteran, newly elected member of the AAKP National Board of Directors, and AAKP Ambassador for the Commonwealth of Virginia, and an overall great person. Ms. Jones is a former dialysis patient and current transplant patient. Dr. Rodriguez, I turn it over to you.
Hi, my name is Rudy Rodriguez, and I'm the Director of Hospital and Specialty Medicine at the Seattle VA, and also the VHA Renal Field Advisory Committee Chair. I just wanted to thank the American Association of Kidney Patients for inviting me today to share some pearls, I think, from the VA kidney program and the response to COVID-19. I wanted to highlight Susan Crowley. She's actually the VHA National Program Director for the renal program. And she's did a fantastic job actually over the last 6 months with the COVID response to the renal program. Also wanted to thank the American Association of Kidney Patients for the Veterans Health Initiative. I think this will really help the VA and has been helping the VA with patient engagement and advocacy with our veteran population. So thank you again very much. And we look forward to continue this partnership, especially with many of the initiatives that we will be rolling out over the next few years. Quote for the day is from Edward Hickey, who many of you probably know well. He actually wrote a nice piece, 12 tips to nephrology teams supporting patients with advanced kidney disease, an advocate's dozen. One of the quotes from his article is, "When you are speaking to a patient, always remember that you have the power to affect their emotional health, confidence, and optimism, and that all of those who care for that person at home. Consider your words wisely." He wrote this in response to a paper that came out in the Clinical Journal of the American Society of Nephrology called "The Emotional Impact of Illness and Care on Patients with Advanced Kidney Disease," which also was a kind of a really focused on the patient-centered care and the experience of patients with kidney disease. Full disclosure, my wife, Ann O'Hare, was the first author of that paper, and she was very happy with the article written by Edward Hickey. What I'll be covering today is the VA health system, just describe a little bit how the VA health system works, and then the VA kidney program within the VA. And then talk also about our VHA Office of Emergency Management and our coordination with that office, and our overall COVID response plan. Just want to describe the Veterans Health Administration a little bit. We consist of 1,200 VA facilities, including about 150 medical centers, 800 community-based outpatient clinics, and also skilled community living centers, or SNFs. Describing what we have, like here in Seattle, we have a large medical facility with all the subspecialties, surgical, medical subspecialties, including a lung transplant program and a bone marrow transplant program that serves the country. But to reach the veterans in this area, we have outpatient clinics all over the region, providing primary care and many mental health services. Our workforce is about 300 employees across the country. And something we're very proud of is that about 90,000, almost a third of all the employees in the VA are actually veterans. So it's ingrained in our HR system, trying to employ veterans within the VA. And overall, we have about 9 million enrolled veterans in 50 states and our territories. The missions of the VA include our health delivery, which includes research and education. So for example, if people in the audience had to take a guess of how many physicians have had some of their training in the VA, think about what your guess would be. But it's actually about a little under 70% of all physicians have had at least some of their training in VA hospitals. And it's almost 50% of all psychologists have also had their training in the VA system. So education and research along with medical care is a big part of the VA. A second mission of the VA is the Veterans Benefit Administration, and that's benefits that help active service members reintegrate into civilian life. And we also have a Veterans Cemetery Administration with decedent benefits for patients, for veterans. So our kidney program is composed of clinical and allied providers who care for veterans with kidney disease. So we have nephrologists, we have physician assistants, nurse practitioners, nurses, dietitians, pharm techs, and a lot of our program is supported by the Offices of Specialty Care in Washington, D.C. So if you think about it, we have probably across the country around 70 dialysis units. Most of our centers have nephrology care. So we would be in the probably top 5 of nonprofit dialysis providers, dialysis providers in the country. So it's a big program with our mission to improve the quality and consistency of healthcare delivered to the veterans with kidney disease nationwide. And we do have national kidney health committees, including representatives from nephrology and nursing, finance, contracting, analytics, and which interfaces with the Emergency Preparedness Office, Public Health, and Connected Care. And we have partners in all the other federal agencies. So focusing a little bit on our response and our infrastructure with COVID, especially with COVID-19 in mind. The VHA Office of Emergency Management is charged with coordinating the oversight of disaster management of the VA. As you can imagine, with so many VA medical centers across the country, we basically function fairly independently until there's an emergency. So that's why this is so important, especially during COVID. And we already had a strategy in place for infectious pandemics. Basically, it was modeled for influenza. So we already have a kind of a playbook in hand that we then updated and made specific for our COVID-19 plan. And the Emergency Management Office worked with the kidney program to make sure that we could deliver kidney care. Unlike a lot of other services, which basically almost came to a complete stop across the country within the VA or other hospital medical systems across the country. Obviously, with dialysis care, we couldn't stop care. So we quickly had to figure out how to provide care under COVID. Our emergency management infrastructure works with other federal agencies, and including we have a fourth mission of the VA. I mentioned the other 3 missions, which is healthcare, benefits, and the cemetery. The fourth mission is that we're really here to help in times of emergencies. And we actually did use this fourth mission of the VA in certain places, which were during the height of COVID-19, including taking patients who were not veterans into some of our VA hospitals. And there's a link there that you can look up some of our infrastructure. So this is our response, COVID-19 response plan. And remember, I'm in Seattle, and as now it seems like a lifetime ago, but remember that in January of this year, the first case of COVID happened here in Seattle, January, I think 22nd it was. And about a month later, we had the first death nationally here in Seattle, also at one of our, not VA, but one of the nursing homes here in Seattle. By then, the VA was already working on its contingency planning and training, looking at our influenza plan and updating it specifically for COVID-19. And I, remember it well in kind of early March of this year, we started getting, remember this was during the flu season. So suddenly patients coming in with upper respiratory symptoms, coughs, suddenly we had to consider that they could be COVID patients. And that's where kind of our initial response happened into phase 2. Really kind of creating a system in place where we could keep patients and our veterans and our staff safe. Our phase 3 plan would have been establishing alternate sites of care. Had we been overrun with patients, we would have worked with our partners to find where we could actually send some of these patients. As you all remember, even here in Seattle, FEMA set up some hospitals where we would have been able to send patients had that happened. Currently, as the pandemic has reached a bit of a plateau, we're in phase 4. And currently in phase 4, we're aligned with other federal agencies trying to limit the spread of COVID-19 infection to our veterans and staff. We're providing care for those infected with COVID-19, trying to provide continuity of care to our non-veterans, and providing resources to Human Health Services, trying to support the national response. We're trying to be as transparent as possible in the VA. This is a website which is open to the public, and it describes basically our active cases and the spots where we've had most of our cases. In the map, you can see that it mirrors basically what happened not just in the VA but elsewhere. Within the VA, we've had 50 currently, as of August 29th, when this data was pulled, we had about 51,507 confirmed cases. Currently, we have about 3,230 active cases, 2,868 of those being in veterans, and about 184 are employees. As far as convalescent cases, we've had over 45,000 cases, over 39,000 of those being in veterans, and 4,304 were actually employees. And we've had 2,873 deaths within the VA. So, we welcome people to visit this website that's listed here, and you can keep track then about our experiences, and you can drill down to any state or city or VA medical center to look at the data. So, as far as the renal program COVID response, our goals were to continue to address the healthcare needs. As I mentioned, we weren't able to stop. This is not elective care, so we've continued to care for our dialysis patients within the VA, within our VA medical centers, and our 70 dialysis units within the VA. We also, of course, focused on the inpatient needs of dialysis. And this, obviously, as many of you heard, became critical in certain states where they were running out of equipment. But nationally, we were able to leverage our support and actually send additional equipment to some of these medical centers, and I'll mention that a little bit later. And obviously, we were able to continue all outpatient care for our dialysis patients in the VA. We've collaborated very closely with emergency management, and we've been able to, as I mentioned in the beginning, Susan Crowley did a wonderful job with our readiness within the VA renal program for both inpatients and outpatients. One of the things we did really early on, and this had already been a big focus within the VA, and that's to provide virtual care. And that's been a godsend, in that we already had a lot of this infrastructure already being mobilized within the VA. A big one was our VA mobile health. We have something called veteran virtual care, and that's how we can actually do visits with veterans. It's a software where we can actually do our clinic visits with veterans at their homes, as long as they have a computer and internet. So that's how we're currently doing a lot of our care, which doesn't need to be face-to-face. So obviously for non-dialysis patients, for our renal patients. We have another program called the Scan VA Echo program. prior to COVID, this is a program which is a telemedicine program, but really is focused on educating physicians. So it's experts with physicians in rural areas, usually providing education. So as you can imagine, when COVID hit, we were able to utilize this program for other purposes related to COVID-19, including education. We have large VA telehealth services also. So this can be from a veteran going to a VA facility somewhere miles from where I am, for example, and then I can actually then use telehealth to actually call in and see them, so in case we can't do the visit at their home. We've also during the pandemic there was a tele ICU service. This included having ICU physicians provide support to other ICUs where the expertise was needed. And finally, we already have a My Healthy Vet vet program, which is a program which allows veterans to communicate securely with our physicians online, from emails to checking on their labs to looking at their notes and other things. So this was actually rolled out even further, and we're currently still doing majority virtual care within the VA system. To meet, inpatient dialysis needs, there is staffing in COVID hotspots. So the VA quickly provided the resources so that we could hire new staff specific to the COVID response, whether these were dialysis nurses, respiratory therapists for ICU care, and this was key in the response. We also, as I mentioned earlier, were able to secure equipment that was actually delivered to some of the places that were really needed, especially for dialysis in ICUs. And as also you can imagine, one of the, as you probably heard in the news, there was just a big need for equipment, including PPE, protective equipment that may all over the country. Luckily, we had this was coordinated across the country within the VA, so that we had our essential supply. If there was an essential supply shortage at one facility, our supply chain officer would then notify the emergency office, and procurement and logistics office would actually then help either with contracting or FEMA to obtain this equipment. One thing I hadn't mentioned also is that our emergency office also has a program called Dept, which is a way of actually sending VA personnel across the country where needed. This is a federal program. So in other words, for example, here at the Seattle VA, we have a nephrologist who's also ICU trained. She was deployed to New York for a couple of weeks to provide ICU assistance there, and deployed again to Texas recently for another 2 weeks. So our facility sent nurses across the country and other personnel to help. And this is a federal program, so it's available for federal employees to go, for example, to the Indian Health Service and other places where needed. So as far as dialysis needs, all our dialysis units follow the CDC guidance. For example, here at the Seattle VA, we started screening patients and staff very early on, so that since most of the dialysis units within the VA system are hospital-based, dialysis patients were screened at the door before they would come into the hospital, and usually screened again when they came into the dialysis unit, screened for symptoms, and then if they had symptoms, they were referred. We had a system in place where our dialysis patients could go into a special area, be tested quickly with a rapid turnaround, so that they wouldn't miss dialysis or would only miss it by a day. So that was implemented fairly quickly. Our medical centers quickly implemented social distancing, hand washing, universal PPE use, and universal face mask is now in place also. So all patients and staff are masking within the medical centers in the VA. We've also been segregating kind of our patients. So very quickly we were able to stand up a COVID-19 ward. So we had an ICU within for example, at our hospital, we had an ICU which was no longer in use. We actually were able to reactivate that area and made it into a COVID-19 area. And we had other places where we would place our patients under investigation for COVID. Luckily, that is come under better control as we now have much faster turnaround for testing. We've done a ton of education, and we really had to stand up our occupational health program very quickly at all the medical centers. As you can imagine, because of employee testing and tracing, this was a large effort. We only have 70 dialysis units across the country, so most of our dialysis patients actually are out in the community. So we don't expect dialysis patients to come to Seattle, for example, if they live hours away. We will send them into the community, and we have all our industry partners. So this worked out well. The VA is part of the Dialysis Service Collaborative Network. The VA issued a waiver to enable facility assignments of our patients in case we had COVID patients. And we also were happy to accept any COVID-19 patients in the community. At our own VA, we're very lucky. We only had one COVID-19 dialysis patient who basically was asymptomatic. We admitted him mostly because of his testing and his housing, but did very, very well. We also have a VA Office of Surgical Services. As you can imagine, with our dialysis patients, they have their surgical needs, including kidney transplant, which is overall done within the VA. We followed the federal guidance regarding tiered surgical services, and we worked hard so that if we had a dialysis patient who needed a fistula semi-urgently, we worked with our surgical colleagues to make sure that happened quickly. So this actually also worked well. For veteran caregivers, we have our support program, and we're sure to provide as much education as possible for our veteran caregivers. As mentioned earlier, part of our mission is also research and development. And, the VA is the largest healthcare system in the country. And that's part of the reason that there's a lot of power within the VA to do research. So the R&D office facilitates partnership opportunities with the NIH. So, for example, many of you have heard about a lot of the treatment trials. So we are participating within the VA, and there was a COVID-19 research committee. So far, 13 awards for clinical trials are happening within the VA, including one on kidney disease. Dr. Edward Sue is doing this one at the Nashville VA, organizing one on the incidence and risk factors and prognosis of COVID-19 associated acute kidney injury. So hopefully more will be coming out soon. Just good to remember, we have to be patient because it takes a while to complete this research. But I think there'll be some exciting breakthroughs and the VA will be kind of leading some of this important research. Currently, we're following what came out on May 8th of this year. The VA issued its Moving Forward Plan to help guide facilities through the national recovery phase using kind of a stage gate process, meaning we have gated process where if we suddenly see infections rising within the VA or particular centers, that we can kind of pull back our care. Because within the VA, safety is going to be our number one our priority on the safety principles and guidelines such as physical distancing, universal screening for COVID-19 patients, source control, and minimal exposure to veterans, caregivers, and staff. We have even remodeled areas. For example, at our VA here in Seattle, we had a subspecialty clinic and then a different clinic elsewhere for primary care. And we actually combined both of those clinics, especially since so much care is happening virtually. We didn't need as much space. So we converted some of our unused areas into areas where we could care for patients who are either suspected of having COVID or have COVID but don't need to be in the hospital. So for example, if there's a dialysis patient who has COVID but is asymptomatic, we needed areas, and all that physical plant remodeling happened very, very quickly, as it did in many other medical centers across the country. And virtual modalities are just continuing for now, and as we think it's safe, we will continue to open more and more care. But currently, when possible, we're doing virtual modalities, including telephone, visits to our virtual visits that we have that I mentioned earlier. So, what can you do? I think the important things, of course, we have our COVID fact sheet, and I think it's been drilled in to many of us now that we have to be safe, we have to socially distance, we have to mask. We have to wash our hands, and we have to be as safe as possible. This is, I think, what will save our medical centers, and this is what's driving the numbers down currently as we see it. So that's what I would urge everyone to do. This here we have, I just quickly will show you many of the information, many of the things I've already mentioned, our COVID fact sheet. We have a web page. Our response plan is open to the public. Our frequently asked questions. Our VHA kidney program has a homepage for all the medical centers in the VA till renal programs. We have an e-kidney clinic that's open to the public. Our apps, telehealth, our My Healthy Vet, and we have a Veterans Health Library also. Thank you again very much for the invitation from the American Association of Kidney Patients. And again, very thankful for the partnership that we've developed. And hopefully you've enjoyed kind of hearing about our VA programs, especially during this difficult time during COVID-19.
Thank you, Dr. Rodriguez, for that wonderful presentation. I have a couple of follow-up questions for you. First, based on your observation and experience over the past 6 months, what are some of the most typical patient exposures to COVID-19 that could have been avoided?
So that's an excellent question. As you recall, I went over in the slides the infections within the VA, and as you saw, kind of overall, almost 10% of infections have been among employees. And I think when the public hears that, I think the assumption probably is, well, our employees are being infected by COVID, because they're caring for patients, but that's probably not true. I would have to guess, but I think probably the majority of the infections happen among employees, out in the public. So that's one of the important things to, I think, especially people in healthcare to remember, is that they have to follow these guidelines, not only when they're here in the medical center, but when they're out in public. I personally, feel safer at work than I do when I'm out and about in the public, because here we can we're all wearing masks. If we are caring for patients, we're protected. We have all the PPE that we need, and so and we do screening of employees and patients before they enter the building for symptoms at least. So you have to remember that some people are going to come in, including employees who are asymptomatic carriers. And that's where we've had, I think, the exposures. But now that there's universal masking and everyone wears PPE, even if you're, a asymptomatic carrier, this is the best way to protect people. So I think that should be the message, is that you should assume everyone has it. If you work at a dialysis unit or a clinic, you should assume you have it, and you may be an asymptomatic carrier, and you have to take those precautions.
Dr. Rodriguez is a senior medical leader within the VA and is chair of the ABIM Nephrology Board. Can you tell me your view on the value and importance of elevating the patient voice, especially that of veterans within discussions about the best standards of practice for kidney patients?
Oh, that's a great question. And, again, that's why I'm here. The patient voice is incredibly important in, I think, changing the way we provide care to especially kidney patients. One thing I'll remind everyone, remember I mentioned earlier, we have a workforce of about 300,000 employees within the VA, and almost a third of them are veterans. So in other words, and remember, veterans will use our VA for their medical care. So whenever I have a meeting within the VA, I know that there'll be a veteran in the meeting because so many of them are employees, and they bring so much to the table, as veteran or as patients or veterans always do, whether it's in our health system or on committees like on the ABIM. I think what they bring are their advocates for their organization. I think the VA is, for example, can be politicized at times, and there have been crises, and it's always so important then to have people that understand the VA, especially veterans, who then are our main advocates because they understand the value of the organization. And I think it's important to have either veterans or patients on committees or as part of the workforce, because they bring the patient viewpoint to all the decisions within an organization. I think when I think about kidney disease and what we've learned from patients in nephrology, I think it's because of our patient advocates and the patient voice that we now watch our jargon, not using end-stage renal disease, the term, not calling patients non-compliant, really focusing on patient-centered care, really focusing on being clear in our conversations with patients, with our language, with our discussions. So I think that's some of what the patient voice brings. But incredibly valuable, and I think we should, incorporate it into all we do within the VA or many of our committees, including the American Board of Internal Medicine.
Thank you very much, Dr. Rodriguez. Next up is Jennifer Jones, AAKP board member, ambassador, kidney patient, and former Marine. Jennifer?
I want to thank AAKP for graciously extending the opportunity for me to share my perspective as a kidney disease patient on the Executive Order on Advancing American Kidney Health Initiative for our third annual policy summit. AAKP granted me the opportunity to attend the signing of the Executive Order last year. My thoughts about it were hopeful because the order proved that the patient voice was heard. This was a result of many people and organizations, including AAKP, working together to bring about change. By witnessing that and engaging with fellow AAKP ambassadors passionate about spreading awareness and advocating on behalf of kidney patients, I knew that I made the right decision to become an AAKP ambassador. I do what I do because I not only understand how important it is to be educated about the healthcare issues and treatment options as a kidney patient, but it is also important for all kidney patients to know what programs are out there to improve our quality of life, what technological advances are being made to give us more choices in treatment, where our elected officials stand on kidney disease, and how they're supporting policies to ensure that all have access to quality care and treatment, and the ability to share our insight and experiences. I am well aware of how fortunate I am to receive the quality of care I have as a retired United States Marine Corps veteran, and the wonderful fortune of receiving a kidney transplant from my amazing living donor, my kidney sister, 5 years ago. Because of this, I want to serve other kidney patients who do not have the same access to treatment, medication, education, and care that I have. When I shared the news about the 2019 executive order to fellow kidney patients, I received some cynical feedback and even outright dismissal by patients who never took the time to read the order. The three major reasons for these reactions were because of either or all. Number one, they have a strong lack of trust in our federal government. Number two, they do not understand the massive detail that goes into achieving and implementing substantive change. Number three, they feel like their voice in all of this is insignificant. They are unable or don't know how to contribute to those goals being achieved. When a kidney patient has been presented with limited care choices since receiving their diagnosis, it is not surprising that there will be a doubt that their situations will change. But now we are transitioning to a time when the needs of the patient come first. Please allow me to help fellow patients and even nephrologists and healthcare professionals who I hope are taking the time to share this knowledge with their patients. Give another perspective to kidney patients who may not appreciate the true scope and positive implications of the executive order, and show them how they can help shape and impact the changes that will be implemented. A 2019 Pew Research Center report discovered that 75% of adults believe that Americans' trust in the federal government has been shrinking. Some worry the government is doing too much. Others say too little, and others mention the government doing the wrong things or nothing at all. If this is the case, then it's vital that we as subject matter experts of kidney disease reach out to our elected officials to educate them about our views and priorities. The responsibility does not fall solely on our government to implement change. It is up to us to hold them accountable, to make sure they see the faces and hear the stories behind the disease so we do not get lost in the noise of Capitol Hill. To better understand the role we play in implementing change, it's beneficial to be aware of organizations and programs that AAKP works alongside, such as the Kidney Precision Medicine Project, the Kidney Health Initiative, Kidney X, the Clinical Trials Transformation Initiative, and the Center for Dialysis Innovation. They play integral roles on the kidney landscape, and the executive order was specifically designed to enhance and accelerate these efforts. I must point out, each of these efforts puts the patient and their unique patient preferences at the center of their deliberations, just like the executive order. I have to admit that the last reason affects me the most. When I share my kidney journey, I know that some consider it unusual. I have received exclamations of surprise and sometimes skepticism. It is not lost on me that when many visualize what an all-American United States Marine who has had multiple combat tours looks like, I am least likely to fit that description. But I fit the description of 35% of people diagnosed with kidney failure in the United States. I fit the description of those who are less likely to use home dialysis or receive a kidney transplant. I fit the description of many who believe that the decision to begin hemodialysis was selected for them instead of being educated on all the treatment options available. If these individuals believe that, then why would they believe that they have any power in contributing to the goals of the executive order being met? Therefore, AAKP launched the Decade of the Kidney because it provides all kidney patients and their caregivers a 10-year strategic view on how to shape the battle space on kidney disease and stay on the fence, both here in the US and globally. We each have the opportunity to become fully engaged community stakeholders in pursuing the improvement of earlier diagnosis and prevention treatments, access to education so individuals can make informed decisions about their treatment and care, greater access to kidney transplantation and technological advancements like artificial kidney, and opportunities to provide patient insight to scientists, researchers, clinicians, and elected officials. Implementation and support of the executive order has become even more crucial because of COVID-19. As of this recording, CMS's preliminary Medicare COVID-19 data snapshot shows that patients with end-stage renal disease had the highest rate of cases with 3,818 cases per 100,000 Medicare beneficiaries. I wanted to close with this. I had to begin dialysis before my fistula had the ability to mature, so I needed a hemodialysis catheter. It was one of the most painful and invasive procedures I had ever experienced. Despite that, I became grateful because it was the connection to the machine that was keeping me alive. When I had it removed after transplant, I kept it. A good friend of mine made this case for me, so I can have this as a reminder that if I can get through this, I can get through anything. In fact, I've had 2 more chest catheters since. Yes, I am grateful, but I am excited about the focus on early diagnosis and prevention, less invasive and restrictive treatment options, and greater access to organ transplantation where one day preemptive kidney transplantation or an artificial kidney can be viable options instead of dialysis. I can't wait to see these changes, not only for those who fall under CMS, but also for kidney patients who receive treatment through Veteran Affairs and the Department of Defense. AAKP is heavily involved in the many positive changes underway at both the VA and DoD, and they are working closely with each department to involve more kidney veterans in their efforts. It is shocking that it has taken 47 years to enact a major change to kidney care in the United States. The executive order is the opportunity that we have been fighting for. It is based in bipartisan principles and the ideal that kidney patients have a voice in their own care and their lives are worth saving through better care and innovation. This requires all of us to take part together in any way that we are capable of doing so. This is not a time to be divisive due to political affiliation, ethnicity, or gender, because both COVID-19 and kidney disease does not care about any of that. The Decade of the Kidney provides the platform for patients, caregivers, nephrologists, healthcare professionals, innovators, and investors to unite in making these goals and more a reality. I appreciate you for taking the time to tune in and for all that you do for the kidney disease community. Thank you.
Thanks everyone for attending today's session. Dr. Rodriguez and Jennifer, we really appreciate your time and the excellent presentations, and you're expressing your views on advancing the interests of veterans in kidney health care. Have a great day.